Good evening. Thank you for joining us for the New South Wales Coal Industry Respiratory Health Standard. My name is Phoebe James and I'm a Professional Development Officer with the Hunter New England and Central Coast Primary Health Network. Before we begin, I would like to acknowledge the traditional custodians of the lands that we are all meeting on today. I'm coming to you from beautiful Awabakal land and pay my respects to elders past, present, and any First Nations people joining us. Just want to mention before we start that this session is being recorded. The recording and the PDF slides will be available in the Education Library in the coming week. If you have any questions, there will be a Q&A session at the end of the presentation, so please put your questions in the question box. It's now my pleasure to introduce Dr. Johan Lemper, Order 43 approved medical practitioner, Happy Health, Dr. David Meredith, Head of Medicine, Coal Services Health, and Professor Deborah Yates, Respiratory Medicine Physician. I'll now hand over to Professor Yates.
Hello. Are you wanting me to start straight away? I need the slides up first.
Yep, yeah, no, I'll get them going. There.
Okay. Right. Thank you. So could we have the next slide, please? Yeah. Okay, so thanks very much for asking me to talk about this topic, which is very close to my heart. These are my declarations. I won't spend very much time on that, but really just to say that I do actually I get referred patients by coal services and am actively involved in a number of different areas of coal mine dust lung disease. Next slide, please. Okay, so tonight I'm going to talk to you a little bit about respiratory diseases, lung function, imaging, and the spectrum of coal mine dust lung-related diseases. And I'll draw your attention to the fact that there is a position paper which we, from the Thoracic Society, published about how respiratory surveillance should happen. And I'd encourage everybody to have a look at that, which is the fruit of much labour and a lot of love. And I'm just going to cover the spectrum of coal mine dust lung diseases and draw your attention also to the fact that the majority of these diseases that I'm going to talk about tonight are probably not those that you would expect. In other words, we're talking about the common ones rather than the uncommon ones, and coal mine dust lung disease is hopefully much less common than the others. Next slide, please. So, just to give you a little bit of a background, really medicine in respiratory medicine has changed hugely over the last 20 odd years, and there has been a huge improvement, not only in our understanding of the basic mechanisms of respiratory disorders, but also in our imaging, and we've been able to do a lot more than we ever used to and look at the lung in very, very careful way. And we've got better ways of doing biopsies, and we've got also better histopathological techniques. So in other words, we can actually diagnose early disease much better than we ever used to. And this is also translated into much better treatment. I don't know whether you're aware of the data that have shown how much better we can now treat lung cancer, and of also the fact that we're treating interstitial lung diseases much better than we ever used to. And although these treatments have on the whole for interstitial lung disease prolonged life rather than actually cured things, at least we have a start. And the other thing that has really changed a lot of our practice has been the global research alliances, which have incredibly increased the power of our study, and also the collaborations between international and national groups. Next slide, please. So we are moving towards different types of diagnosis. And one of the things about the older types of diagnosis is that the methods are quite insensitive. Now, that may or may not be a bad thing, because whether you actually help people by diagnosing early disease or not is a topic I'm not going to cover too much tonight. But you'll remember the traditional chest radiograph up on the left, and the improvements that we made in CT scanning. And CT scanning is much more sensitive for not only diagnosing, but also delineating the different changes in lung diseases. And then we've got new methods of doing lung function. On the right at the top, there's this gentleman who's doing spirometry, but we've moved beyond that now into things like exhale breath testing. and you can actually look at the breath profile and hopefully diagnose lung disease from that. And then in the center, we've got the advent of AI, which I think will make a difference, but we haven't quite got onto yet. But we are already applying certainly in CT scanning with AI algorithms. Next slide, please. So I think just wanted to mention a couple of things that are actually quite important, which a lot of people forget, and I'm sure you won't because you'll be used to this. But in health and safety things, it's quite directed towards immediate results. You know, if you have an industrial accident, it's obvious what the cause has been. But if you're looking at respiratory disorders, and in particular mine dust lung diseases, they have a very long latency period. And although this is unusual for some diseases, it's actually quite common in respiratory medicine. And the archetype is actually pulmonary tuberculosis, where you'll remember you have latent disease, and then 20 to 30 years afterwards, you can get reactivation of that, particularly using a lot of immune suppressants. And therefore, it's really, really important to get the right occupational information very early on. And the data collection that one does in the future will be really, really helpful. There are actually modern data collection methods which have really had remarkable results in terms of tracking the etiology of lung diseases. And probably the Scandinavian example is the best, where they have a centralized system, and they've published quite a lot of studies where they've made the link between early exposures and the outcome of disease 40 odd years later. And you'll remember that things like occupational asthma still have a latency period, but only a couple of years. But coal workers' pneumoconiosis nowadays, with the lower dust exposures, is up to 40, 50 years, and mesothelioma is actually increasing. So one has to delve back into the past, and this is inevitably inexact. Next slide, please. So what are we going to discover with the respiratory surveillance techniques that are much more sensitive than we did before? Well, we'll probably, hopefully, find not very much, because we do have a healthy population. The majority of these people have actually been selected for being healthy. And then we'll find the diseases that are commonly found in the normal population, particularly asthma. Airflow obstruction from either COPD or asthma are probably the likeliest things that one will pick up. We certainly see this in a clinical context on a day-to-day basis. And then the next commonest thing that we see is actually respiratory infections, which is one of the reasons that we've asked for repeat testing, for example, with spirometry, because although it's often not appreciated, if you've had a respiratory infection within the last 6 weeks or so, it can actually affect your spirometry quite badly. And people tend to forget, particularly young men who are quite fit, and they brush it all off, but any small viral infection will certainly affect spirometry. And then it'll be much less likely that we'll actually find things like pulmonary fibroses, the lung cancers, the rare genetic conditions like alpha-1 antitrypsin diseases, and Bertog-Dubé and things like that. But the other interesting thing is that we're finding more and more dual pathology and detecting a whole load of things that we never would have found before, which is actually good in the majority of cases, but does make it a bit more difficult. Next slide, please. So the commonest disease in younger people, as you know, is asthma. And asthma itself has been revolutionized in the last 20 odd years by different types, as you can see there. And the diagnosis is significantly assisted by spirometry. It's not made by spirometry. Asthma is a clinical diagnosis involving symptoms, signs, and investigations. But it is definitely assisted by spirometry, and it's actually quite a good predictor of likelihood of asthma exacerbation and also of asthma death. So it is very useful. On the whole, it's not caused by coal mine dust or silica dust, and the advantage of finding asthma in young people is it's actually very treatable. It's very much more treatable than it ever used to be, especially with the modern biological and agents, and also LABA, inhaled corticosteroid treatments. Next slide, please. And just to mention quickly the use of the fractional exhaled nitric oxide test. This is a simple breath test, which we actually were involved in developing 30 odd years ago. And if you go and look at the very original papers, you can see me there actually breathing into the machine and my exhaled nitric oxide test, and also the fact that it goes up in respiratory infections because we had an outbreak of a nasty flu illness, and we were all measuring ourselves in order to document this when at the Brompton. But it's quite a useful test. It's not perfect, none of them are, but it is a very good test for actually looking for eosinophilic inflammation. And that in itself is a test for potential treatment. So it is actually a useful test to do. And that's something which I think will be increasingly used in the future, and hopefully other breath tests as well. It has prognostic as well as predictive effects. Next slide, please. So the commonest disease in older people, of course, is COPD, and in the majority of cases, this will be smoking related. And you'll remember that COPD actually comprises a whole load of other diseases. There are sort of subtypes that are now mentioned a fair amount, and it's not always due to smoking. I mean, the vast majority of cases probably are because of the past smoking habit of most men in particular. But with the changes in the smoking habits, we've actually discovered a large number of other types of diseases, and that has really opened our eyes to the possibility of other defects that have caused this. And one can go way back into history. I mean, particularly, for example, to children when they're first born, childhood nutritional insults, viral infections, and so on. So we will find a large number of cases of COPD. This is a diagnosis that is actually made on the basis of spirometry, although increasingly it's made using high-resolution CT demonstration of emphysema. And although we don't use that very much in this country at the moment, you can actually also look at airway disease using CT scanning. And both components actually will give you an identical spirometric pattern unless you use DLCO testing as well. Now, COPD is largely regarded as, end stage, but actually that's not true because it's treatable if you detect it in its early stages, and that does include removal from coal mine dust and also smoking cessation. And that's probably more than one can do for people than all of the treatments afterwards. So it's really worthwhile. And of course, you'll be aware of the recent data on vaping. We don't know how that's going to translate into lung disease in the future, but it probably will end up with a COPD-like picture. Certainly the changes that have been developed so far with Evalia, probably bronchiolitis obliterans. Next slide, please. So this is just a short reminder of measuring lung function. I know that you do this all the way through, and you'll know the differences between obstructive and restrictive patterns. I don't need to go through that. But just a quick reminder that the GLI, the Global Lung Initiative, has produced global lung predictive values that are based on hundreds of thousands of people in a variety of different populations. But spirometry in itself is still pretty insensitive for early disease. So when we pick up people with abnormal spirometry, we're not selecting on the whole for early disease, and the bar is actually quite low. So these are people who already have established disease by the time they have spirometry. And spirometry is a very good predictor of overall mortality. And the other thing about spirometry is that in individual groups, for example, in the Aboriginal groups or people who haven't had, huge numbers of lung function measured with normal people, then the prediction equations are sometimes rather inaccurate. So they can result in over or underestimation of the levels, and therefore it all needs to be taken with a pinch of salt, as does the measurement of longitudinal decline, because we don't have hundreds of thousands of people measured over 50 odd years for spirometry, all their longitudinal readings. We have some, but over the more recent years rather than the initial. So the current predictive values are actually calculated from cross-sectional rather than longitudinal ones, which means that they may not be entirely accurate. But actually, individual decline in an individual person is probably much better than doing it from cross-sectional values. So this is one of the reasons for actually getting a lot of different spirometric readings when you can. And essentially, like all things in life, the more the better. Next slide, please. So if you look at lung function trajectories, again, this has changed a lot since the Fletcher-Peto curve that was done many years ago. And now in respiratory medicine, we're recognizing the effect of antenatal, of childhood, adolescence, and adult insults. And if you look at this slide, you can see that the green one is actually the normal curve, which hopefully is you and I. And you see we start off without any childhood insults. We grow to normal levels, and then we decline very slowly, in which case we'll have no problem with our lungs in the future. But if you're premature, if you have birth complications, if you have genetic defects, your initial lung function will be very low, and that will be a predictor towards long-term lung function in adulthood. And you can actually affect the trajectory of decline, depending on how treatment is offered, depending on what sort of effects are implemented early on. So one really does need to go way, way back. And some of the people that we will be picking up with the surveillance program will be those who actually who have got long-standing lung function abnormalities, which are not necessarily related to anything to do with work, but actually have not been picked up before. And those people on the whole tend not to have too bad a longitudinal lung function loss, but they will start at a low baseline. So we will pick up a few of those, and hopefully in a few years we'll got rid of some of those, because there'll be an extra effect, because there'll be more of them who haven't been detected so far, until such time as every general practitioner is using spirometry all the time, which I think is probably a bit too much to hope for. And the other point is that workers tend to be healthier than those in the general community. So we hope that the lung function decline will be less, and that we all have a fairly good reserve in our lungs. So it's not like cardiac disease. We have two lungs. We can function sort of fairly well. But if we can reduce the rate of decline, then we will actually have a significantly lower level of disablement in old age, particularly as people are living much longer than they ever used to. Next slide, please. Okay. So just to get onto the classical pneumoconiosis, as you will remember, these affect the lung interstitium and can cause lung function abnormalities, and there are a whole load of them. And the vast majority of the ones that we see are coal workers pneumoconiosis and silicosis. And actually, probably both of these are really a mixed dust fibrosis, because in practice you never get just one dust inhaled, and the pulmonary reaction to dusts does depend on the combination of different dusts. But there are a whole load of other ones, and it's very difficult to actually sometimes partition out the differences between them. And most of them are actually due to inorganic dust inhalation, and I haven't really talked about things like hypersensitivity pneumonitis, but you'll remember that there are other ones that are due to metal, and that there are a combination of factors that can be involved in this. The interesting issue is whether you can actually get chronic granulomatous disease from dust exposure, and sarcoidosis with silica exposure is quite a hot topic at the moment. So just because you see something on an X-ray that doesn't look just like classical pneumoconiosis, it doesn't mean that it doesn't have some occupational component, but it doesn't fit into any particular category at the moment. Next slide, please. So I'm not going to go into the details of all of this too much, but silica exposure and other exposures, particularly tobacco smoking, are actually much more common than single exposures. And although we look at the classical descriptions of all of these diseases, they're really at the spectrum. Silica will give you usually a mixed dust because it's usually inhaled with a whole load of other dusts. So the ones that we're looking at are actually with classical silicosis, it's due to the percentage of respirable crystalline free silica. And mixed dust fibrosis will occur with varying percentages of respirable free silica inhaled. And progressive massive fibrosis can occur with both. It can also occur with asbestosis. It's documented with other types of pneumoconiosis. So it's not specific to any particular type. And one should also remember the fact that PMF or nodular lesions can actually look very much like lung cancer. And these people are actually at a raised risk of lung cancer from other things that we are not necessarily always aware of in the mining environment, that they would have been there. And if not in a current occupation, they may well have been in previous occupations. So actually a high index of suspicion is sometimes life-saving in these people. Next slide, please. Okay. So the spectrum of disorders associated with coal mine dust exposure include the classical pneumoconiosis, but they also include COPD. I'm going to talk a little bit about that. And they also include the occupational upper respiratory tract in cancers, often due to, for example, other inhalations. DPM, for example, would be one of them. There may well be other agents. We don't tend to get too much in the way of pleural disease with coal mine dust exposure, but you do get definite pleural disease with silica exposure, specifically mainly in the upper lobes. And then you get a whole load of other diseases. Hypersensitivity pneumonitis, diffuse dust fibrosis, which looks just like idiopathic pulmonary fibrosis, and in particular respiratory infections. And one should always think about tuberculosis and atypical mycobacterial diseases. So essentially you can get anything you care to mention in coal mine dust lung disease. But the main one, as you'd expect, would be the pneumoconiosis and the occupational COPD and the mixed dust fibrosis. Next slide, please. Okay. So I'm not going to go through the different subtypes of silica exposure because I'm sure that you're aware of that. Acute silicosis, chronic silicosis, progressive massive fibrosis, the airway disease that's associated with silica exposure, and also the infections. You get at least a 3 times increased relative risk of tuberculosis and also other fungal and bacterial infections. Interestingly, you tend not to get bacterial pneumonia. That tends to occur with welding, particularly pneumococcus. And then you get the autoimmune diseases. And you're probably also aware of the fact that scleroderma and mixed connective tissue disease and rheumatoid are now actually recognized by eye care as being silica related and compensated appropriately. And then the other thing I think that we need to think about a bit, but perhaps not in this presentation, is the stress-related disorders that occur, particularly after you've been given a diagnosis of silicosis, because there's been a lot of publicity about it. There's been a lot of anxiety. People are very worried about their work. And that's actually one of the issues about making a diagnosis, which can be very threatening to people. So I think we have to be very certain about our grounds before we actually make such a diagnosis. Next slide, please. So this is just a picture of the different types of coal workers pneumoconiosis. You'll remember how different it looks from most types of lung disease, particularly in the upper lobes. And these are the small areas with category 1 disease. And they haven't yet in this slide progressed to progressive massive fibrosis. And normally you have normal lung function, but you can hopefully see there are small areas of emphysema there. And that is actually well documented to occur with coal mine dust in the absence of smoking and is definitely a coal dust effect. But at this stage, lung function is usually normal unless you exercise someone or you do sophisticated lung function testing, particularly measuring DLCO. Next slide, please. And the next slide is just a picture of mixed dust fibrosis, which, as you know, arises from different combinations of dusts. And also, out of interest, the fact that you can get some ferruginous bodies from coal dust rather than just asbestos exposure, and that any dust which is inhaled will modify the effect of the other dust. Next slide, please. So this is a very characteristic Medusa head appearance that you get with mixed dust fibrosis. And I wanted just quickly to highlight the fact that you do get diffuse dust fibrosis or dust-related diffuse fibrosis, which is pretty rare, but definitely happens. And it's been described in other places for many years. And it looks identical to IPF. And that's one of the reasons that I'm always on at my colleagues to actually take a very detailed occupational history, because if you do take a very detailed occupational history in these people with so-called IPF, you'll find an occupational component probably in about a third of them. So that's a significant number. And this is the sort of thing that we do treat with nintedanib and pirfenidone, the new antifibrotic agents. Next slide, please. Okay. And just to mention silica-related lung cancer, we're probably going to be seeing more and more cases of this in the future because, as you probably know, from May next year, they're going to be implementing a lung cancer screening program. We're very pleased about this in the Thoracic Society because we've been campaigning for this for years because it definitely does save lives. But silica-related lung cancer on the whole, again, suffers from the same problem with other types of occupational lung cancer in that it's not recognized. People always assume it's due to smoking, but there's definitely an increased risk with silica exposure itself, not only just with silicosis. Next slide, please. So to conclude, Australia is probably going to see lots of cases of dust-related lung disease into the next century even. And respiratory surveillance is changing and also will be affected by the lung cancer, and other screening programs are going to be increasingly implemented for normal population. Our treatments are improving, so we actually will save a large number of lives with this. And I think it's our responsibility to try and ensure that this is done without having too much of an adverse effect on our workers. We want to make sure that the whole situation is not too anxiety provoking, either for them or for us, and that we do it in a way that actually improves not only respiratory health, but also people's overall health and also their quality of life, so that they can enjoy their retirement with good health. However, having said that, we all know that nothing is as good as prevention, and that's what this whole system is all about. The idea is to prevent rather than to actually treat disease, and the aim of a respiratory surveillance program is to do the respiratory surveillance and have no cases. That doesn't mean the program is not working, it means that it's working well. Thanks very much.
Take that off. Thank you very much, Debbie. Hello, everyone, and thank you for the opportunity to take you through tonight some of the changes we have in the screening and management of lung disease in the New South Wales coal industry. So, lung monitoring in New South Wales coal miners has been going continuously for just under 80 years. And when things kicked off in 1947, I just better click into the screen, things were in a sorry state. The industry was very primitive, conditions were dangerous, and 16% of our workforce had black lung at that point. Now, things have obviously improved, and over the following years, the way we actually screen for lung disease has remained largely unchanged for decades. There have been a few tweaks, but nothing much happened until 2015 when black lung was re-identified in Queensland, and that provoked a huge amount of interest in these diseases and how we screen for them. And in fact, it prompted a group of concerned respiratory physicians and occupational physicians and radiologists to come together and form the Coal Mine Dust Lung Disease Collaborative Group. And in fact, Professor Yates was one of the co-chairs of that group. And it met a number of times through 2016 and 2017. And towards the end of 2017, it presented a clinical pathway that doctors could follow to investigate lung abnormalities in coal mine workers. And that was a major step forward. And then a few years after that, we had the Thoracic Society release a position statement on respiratory monitoring for coal mine workers and artificial stone exposed workers. And that recommended greater use of spirometry, introduction of gas diffusion testing, greater use of high resolution CT scans, and also introduction and study of using some of the new and emerging methodologies that Professor Yates just mentioned. And then a couple of years later, the Workers' Compensation Regulatory Services in Queensland published a guideline on what to do when you were looking at a worker with identified mine dust lung disease. What criteria could you use to return this worker to the mining environment? What sort of exposures were acceptable? What follow-up was needed? And this actually completed the cycle that had started with that collaborative group years before, because that pathway helped us identify cases of lung disease, but it didn't lead us to a guide on what to do around it. And so this was another important step on the way. And whilst that was happening in New South Wales, the Mine Safety Advisory Council lobbied the resources regulator to conduct an independent review of the health screening program for coal mine workers in New South Wales. And that proceeded through much of 2021 and finished up at the end of 2022. And a report was handed up to the MSAC in February last year. And that had conclusion that overall the program was robust, but it also made a number of recommendations in how the program could be improved. And the following month, the MSAC accepted all the recommendations in that review. Now, a month later, in April, Resources, Safety and Health Queensland released a new clinical pathway for investigating abnormalities in mine workers. And this actually incorporated a lot of the recommendations that were made in that position statement by the Thoracic Society a few years earlier. And then in the middle of last year, the resources regulator directed coal services to start implementing all of the recommendations in that review. So that takes us to where we are at the moment. Fundamentally, the screening still relies on looking for abnormalities with symptoms, unexplained respiratory symptoms, changes in spirometry, and that may be a change in the pattern of spirometry. It may have gone from normal to obstructive or restrictive, or it may show a loss of volume that is in excess of what we'd expect from the normal aging process. And we then also look for changes on x-rays that could be emphysema, it could be nodules, could be pleura, something that could be consistent with a dust exposure. And nothing overly much has changed in how we investigate the symptoms or the X-ray changes. They usually still wind up with an HRCT and perhaps a respiratory physician assessment. But there have been some major changes in how we follow up on lung function abnormalities. This next slide's a bit busy, but essentially what it's trying to convey is whenever we identify some abnormal spirometry, we need to investigate it and try to explain why is it abnormal. As Professor Yates mentioned, these diseases can be multifactorial. So just because someone has asthma or might be a smoker, it doesn't mean that they don't have some coal mine dust lung disease in there as well. And so the process starts with some bronchodilator responsiveness testing, and then moving on to gas diffusion testing. Now, we call it complex lung function testing. I know that's not its official respiratory science name, but we do it to distinguish it from spirometry alone and also maintain some consistency with the Queensland pathway, which also uses that terminology. And if abnormalities are detected at the complex lung function stage, then that normally determines whether they go on to have high resolution CT scanning and perhaps a referral to a respiratory physician. In general, the more severe the abnormality with the lung function or abnormalities detected on the HRCT, those will normally result in a referral onto the respiratory physician. When these abnormalities are identified in an existing New South Wales coal miner, the coal services or Order 43 doctors will generally initiate that referral process and organise those tests. And we will follow that testing through until we get a diagnosis. What we ask when we refer these people to the respiratory physician is for the respiratory physician to give us the diagnosis they feel it is and the etiology, and also any treatment or follow-up that they would recommend. We don't ask the respiratory physician to certify the mine worker for their fitness for work. That remains the responsibility of the authorised Order 43 doctor. But if they are an existing coal mine worker, that process we will fund and pay for their testing and the referral until we get a result. At the end of that, if there is something identified that does require some ongoing care, then we refer that mine worker with the results back to their treating general practitioner to continue with. The area that probably caused the greatest shake-up in the industry was recommendation 14, however, and that's what do we do when we identify lung disease? And if you look at the recommendation, there are a number of words in there that were very dramatic in effect, and that is when we identify coal mine dust lung disease or other non-occupational lung disease. So basically, it's removed the distinction or practice that had been in place for quite a while, that if we identified lung disease that was attributed to mine dust, we would take precautions and protect them from further exposure. But if it was something else, we wouldn't. We'd just allow them to continue working, providing they had sufficient capacity. That approach was rejected, and the reviewers were quite clear that it wasn't an oversight. They intended that they took into account that in many cases that they reviewed that it hadn't been attributed to coal mine dust, but they said we need to take a different viewpoint, and it needs to be when we do identify a lung disease and that lung disease is causing some impairment to the lung function, we need to be looking to the future to protect the remaining function of that mine worker so that they will have enough lung function for a comfortable retirement and older age. And so it's not so much the diagnosis, it's is that disease process causing some degree of impairment that is now important from a management point of view regardless. The compensation issue is a separate thing. So we look at this from the perspective of changes in x-rays or changes in lung function. And so once the x-ray is showing simple disease grade 1 dash or slash 0, those restrictions to dust exposure will normally come into play. They may also come into play with other conditions such as emphysema, and we then track that mine worker a lot more closely. If the disease is actually progressing, then those restrictions are tightened up. And eventually, if that person either continues to deteriorate at a rapid rate or they reach a grading of 2/2, then normally there'd be a recommendation to exclude from further coal mine dust. In the lung function space, we're looking at either their forced expiratory volume in the first second or their diffusing capacity. And once either of those drops below the lower limit of normal, it may be appropriate to introduce some form of dust exposure limit. And once again, we follow that. If it's deteriorating, that limit will be tightened up. And eventually, if the FEV1 falls below 60% of predicted or the diffusing capacity below 40% of predicted, then it may be appropriate to remove them from further mine dust exposure altogether. All of these workers will have at least annual monitoring with the complex lung function test, and depending on the diagnosis, there may also be further scans and or respiratory physician assessments. So these things were all incorporated into an overall respiratory standard that was released recently for the New South Wales coal industry. Certainly a large component of what we're looking at is how we manage and investigate lung abnormalities regarding potential dust exposure, but it also looks at all the other areas in coal mining where lung function abnormalities may actually be important and affect the safety of the worker or have some other maybe detrimental effect on lung function. So it's not just confined to dust. There's also a lot of information in there on quality spirometry and how to interpret the tests and how to use other things to assess severity of asthma, such as, I've forgotten the name of it, Deb. The
Fractional exhaled nitric
GINA,
oxide.
the GINA
oh,
side.
Global
Yep.
Initiative for Asthma. Yeah.
Yes, and COPD with the gold. So there's other information there, and also support materials for workers and employers, and that's all available on our website if anyone is interested. So I think that's probably the end of mine, and I'll hand you over to Dr. Johan Lemfer. Thank you.
Thank you, David, and thank you everyone for your time. My name's Johan, work as a GP in Charlestown, and for the past 7 years, I've also led a medical team at occupational health provider Happy Health. We're based in Warners Bay. In case I need a disclaimer, I've enjoyed many a free lunch provided by Coal Services Health in exchange for my time as a GP representative on various committees. And one of the fun things I get to do with occupational health is enjoy the challenge of negotiating having coal employers as clients and also coal workers as patients in my GP space, and trying to work out how to advocate for good health outcomes in both of those situations. And unsurprisingly, one of the biggest challenges that I'll encounter with coal workers, and that you no doubt do as well, is helping them to see the value of the health monitoring systems that are in place for coal workers and for any other employer for that matter. Look, while some workers will welcome it when they turn up for it as the only time that they ever see a doctor, and for them I try to provide education on the value of having their own actual GP, many workers understandably see it as a burdensome barrier to employment that justifies any lengths that they sometimes go to get around it. One thing I'm looking forward to from the new guidelines is that there will be some new additional resources for GPs, and hopefully we'll be able to see some guidelines there, or some handouts there for GPs to use when discussing some of the results and some of the outcomes with workers. And that new guideline will hopefully provide a bit of clarity for GPs, similar to how the Assessing Fitness to Drive or the rail guidelines can help out when you're trying to jump through employment hoops for your truck and train driver patients as well. Now, the two short cases we've got tonight, to leave time for questions, just examples in longitudinal monitoring. David, if you want to bring up the first one there. The first one is a 29-year-old male, and like many workers do, they will bounce between New South Wales and Queensland coal sites, depending on where the best job offer is with the most attractive roster. And so he's been in the industry since 2012. His first medical in New South Wales with us back in 2016 was crystal clear. No history of lung disease, never smoked, no symptoms, and a normal spirometry. However, that has gone through in 2020 because we will normally see them every 3 years on average. When we reviewed them in 2020, if I can see the next slide, David, what we're seeing now from a previously normal spirometry is what's probably best described as a mildly restrictive kind of pattern there. If you can see there, the little asterisks across the board attached to each FVC, letting us know that those values are all below the lower limit of normal for that worker's gender, height, and age. As you can see there, FEV1 is below the lower limit of normal, and as in 2020, it wasn't mandatory for coal mine workers to have any bronchodilator response testing done. That hasn't been done at this point in time. And as any coal worker who comes in with an abnormal spirometry like this would have done at the time, as long as they are asymptomatic, and they almost always are, and they almost always have had a cold in the past week or two when they present for us for a spirometry, they had a normal chest x-ray, no sign of cholexia pneumoconiosis on that, so they would have been referred to their GP, hopefully with a copy of the spirometry and a little note saying, please have a chat with the worker and let us know if there's any further things that we need investigation. And if you do receive one of these letters from a Order 43 coal doctor, then by all means, please follow up. And if you actually do want any of the previous information, because Coal Services does have their spirometries going back a significant portion of time, you can request, or the worker can request those. It's similar to how you can request additional information from the hospital system, as long as they request it specifically, which things, their bits of data they're after, signed page there, and they can obtain forms from the Coal Services Health website, which can guide you through how to go about requesting those. So he's had that review in 2020, then in 2021, we had no spirometries because of COVID restrictions, which delayed his 1-year review to 2022. And here we've got a mixed pattern. as you can see, there's been a little bit of a decline. So the values there have gone from, I think, 80% FVC has remained stable, but their FEV1 has dropped from 71 to 66. And is that significant? Is it not? It's hard to tell, especially if, as I said before, they inevitably come in saying that they're just getting over a cold, because no one likes performing spirometry. But we've got that FEV1, 66% are predicted now, and again, that kind of review without a significant deterioration, without any symptoms, and with a normal chest X-ray less than 3 years old, would have gotten a nice little letter to go say, look, please go and see your GP with these results, in the hope that they might be more forthcoming with their regular GP about whether they actually have any symptoms or not. Now, we have a look at the next slide. Good. Okay, so fast forward another year, and 2023, it's gone back to more of a restrictive pattern. And under the new guidelines at this stage, they now automatically will score a bronchodilator response testing, which just happens immediately, and that's been very, very useful in trying to get some additional information for these workers. And on this, they haven't seen a significant improvement or response with bronchodilator. Their FEV1 remains below the lower limit of normal, but otherwise we haven't really seen a significant change on comparison to, in some values, on comparison to the previous spirometry from the year before. But under the new guidelines that were had been brought in 2023, they are now also scored a complex lung function test. And if we could have a look at the next one through there. So complex lung function testing, as David just described there, is spirometry with DLCO as a fairly standard. And that confirmed the mild obstructive pattern. And for some reason, whenever the workers do go and have formal spirometry done at a lab, it almost inevitably is better results than when we've done it at our facilities. And some of that could be to do with more expensive machines and better trained staff. That's possible. But I also do think there is a significant impact of a worker being scared for their job, actually really putting in a solid effort and listening to what they're being told about how to actually conduct these medicals. But I could be wrong with that, Deborah. Apologies. The CLFT showed FEV1 below lower limit of normal. Again, not that different to the spirometry that had been collected previously outside a respiratory lab. Same positive bronchodilator response test, but I think it was only a marginal positive, and a normal DLCO and a normal TLC. Now, the degree of abnormality on that test is enough to score them now a high-resolution CT, and that has shown what we described as how would you describe that, Deborah? It's it's fibrotic abnormalities, but if you were looking at that,
yeah, I'd be worried. So, I mean, I always look at the CT scan because I think it's so much better than actually just looking at the report. But it looks like it's got apical scarring with pleural thickening as well as interstitial fibrosis in the lower lobes. So that's significant in a 32-year-old or whatever he is now. That's significant. You wouldn't expect that normally. There's a big differential diagnosis.
Oh yeah, and again, it's vital to try and get the GPs involved at this point in time. When if I'm seeing a co-worker in occupational health space, really we'll try and get them to see their GP, see if the GP can get more history out of them as well, and whether they actually have any additional symptoms or any additional factors there, because they often don't disclose everything that's going on to their occupational health doctor, and that's understandable. And I believe this patient was referred off for a respiratory physician review at this point.
Yes.
Yep.
Yes.
So
yeah, we haven't got an outcome yet, but definitely referral, and it is very interesting because he's a young worker, and we certainly don't expect that, but he's clearly got that change in his spirometry that's been persistent, and obviously there's something happening. Yeah.
Yeah, he's not a smoker.
no.
No. Yeah,
No.
so you'd be looking for interstitial lung disease, you'd be looking for autoimmune disease, and also things like psoriatic lung disease. And because the point about all this is that you can actually, if you pick these up early, the treatment options are much better than they used to be even 5 years ago. So you may well be helping this man with long-term pulmonary scarring.
Yep. And as another point, if in GP land you do have a patient that you come across who is a coal mine worker, and for some reason you investigate symptoms and this comes up, that is definitely the point at which you then put them back into the coal services health system as well. If you can just refer the same way that you'd refer to any other specialty with whatever the information you have at hand, then coal services will pick them up at that point. And as David said earlier, we'll conduct as many investigations and take it as far as is required to get a diagnosis if we think that their work has contributed as a coal miner. We'll move on to the next case, if that's all right. Yep. So the next one is in some ways probably a little bit more what you'd typically expect to hear coming out of a coal mine worker health monitoring space. 59-year-old male, long-term underground coal miner, also long-term underground smoker, except underground, it's very common. What's most surprising with him is that this is all fairly recent. This has come up. There's had normal spirometry largely for a long time there. Then we started to see the prism pattern starting to play out, so preserved ratio impaired spirometry. And this has continued that way following the 1 year monitoring for a couple of years through there until he triggered a referral to a GP. And then the 12-month intervals dropped to 6-month intervals as we started to see more changes through there until he's come back again in 2023. And if you have a look at the results from the next slide. Good.
Although
yes.
that spirometry is the 23 spirometry.
Oh, that was the 23 spirometry. Oh, sorry.
Yep.
Apologies. Yes. So, I mean, as you can see here, preserved force vital capacity, but we've now got an FEV1 that's dropped to 66%, and we've got a bronchodilator. Oh, not sure I'd be that convinced about what that shows, but yeah, so there is a response. Sorry?
Yep, it's significant. The new guidelines are 10%, which is actually easier than 12%. It used to be 12% 200 mils, so now it's 10%, so that's easy to remember.
And so we've got significant changes through here that they've gradually progressed through that prism pattern to what you can see there. And under the new guidelines, that would then score them a complex lung function test done again. And I believe that's on the next slide, David?
Yep.
Yep. Complex lung function tests that have happened earlier this year, again, confirm the mild obstructive pattern. Has the positive bronchodilator response test, so it does still look obstructive in that regard. FEV1, again, below the lower limit of normal, but 72%, and a mildly impaired DLCO. But with that, under the new guidelines, that would then score them a HRCT, and the HRCT is a lot of words on the page, but essentially, again, not good, very concerning, and a mixed pattern, probably with some contributions there from the smoking history. In addition to nodules, very suspicious of a dust-related lung disease, and on respiratory physician review, ended up being diagnosed as COPD, some mild emphysema, but also simple coal workers pneumoconiosis. And again, it is still happening, and that's a recent diagnosis, and that worker's treatment, I believe, is ongoing.
Yep.
We only have, 6.5 minutes left, so I think it's probably time for questions if there is any additional.
I can stop sharing there.
Amazing. Thank you so much. We do have a few questions come through. So thank you to everyone for sending through your questions. And whilst we're answering these, please feel free to send through any more. Johan, we'll start with you because a lot of the questions are around the case studies. With the first case study, what was his BMI?
David, have you got the data up in front of you for that?
I haven't got it in front of me. That's certainly one of the things we look at when we're pulling these cases out, and we actually have developed our own little bit of software that allows us to pull out all their data, their BMI, their results from all their encounters. Plus, it allows us to standardize the height, because you'll often find when you look sequentially, that they rise and fall by a few centimetres over time, and our measurements of late are a lot more accurate. We use the laser things and that sort of thing. So we standardise that. We have a look at their BMI, and we convert all the results into GLI reference ones. And so if there's been a significant change in BMI, yes, we're looking at that. That may be a contributor. I don't think it's that much of an important thing in the majority, and I'd defer to Deb Yates there.
Yeah, I mean, you have to have really quite a high BMI to have it affect your lung function. Normally, it's forced vital capacity, and your expiratory reserve volume goes down. But it also depends on where the fat is spread around the chest. So normally, if the BMI is under about 30, you're probably okay.
Sure, thank you. How do we refer back to Coal Services? Is that via the portal?
The best way would be to give the mine worker a letter with the information and ask them to contact Coal Services and request a review, and we can organise that as a special assessment.
A question for Professor Yates. A lot of coal miners who are obese or a bodybuilder that came in restrictive pattern spirometry and DLCO are usually normal or sometimes CW abnormalities. Do they need a follow-up?
Probably not. But I mean, if you actually look at the risk factors for death, being overweight is sort of way up there and probably more important than coal workers' pneumoconiosis, actually. So, yeah, they probably do need a follow up for other reasons, particularly if they're very overweight. But it's debatable. If we had an easy answer to how to stop people being overweight, other than Ozempic, I'm sure that we would be very wealthy.
Johan, you did mention that GPs can request past spirometries. Do allied health professionals have that authority as well if they get permission?
It's usually, so the Order 43 GPs can request spirometry directly from Coal Services Health. Otherwise, it's probably easiest to get the worker themselves to request that directly from Coal Services Health. And there are forms available on the Coal Services Health website, which they can use to fill that out to request. David, are there any direct lines that GPs can use to Coal Services?
As long as we've got an authorised, some written authority, we're happy to release. The reason we are a bit cautious is we're in a fairly hostile industrial relations environment in coal mining between a very powerful union and very powerful employers, and our mine workers get very antsy about what is being released where. And so we won't normally release their data unless we have their written consent to do so, unless it's an emergency situation. But so that's all we ask. If they give us an authority that the person signed, we're happy to release any of their data.
Sure. Is there an allowance for the difference in height? What is considered acceptable over the years?
Yeah, there is. I mean, that's the whole point about having Global Lung Initiative predictive equations. And so height is taken into account, as is age, as is sex. And ideally, racial factors would be in there as well. But at the moment, we're not too brilliant on those because we've just got the vast majority of the data due to, with white Caucasians. But yes, height is definitely taken into account in the predictive values.
When working at the decline in spirometry, is the measure based off the worker's baseline spirometry or their last, like most recent spirometry?
Essentially, both. So there is actually a very, very useful It obviously depends on how long the previous spirometry has been measured before. I mean, if they've been measured, say, 30 years ago, then you would probably expect more than 15% decline, but otherwise you wouldn't. But certainly, it's a bit of an arbitrary cutoff, to be honest. It's what is recommended by the occupational medicine group in America, and it has been sort of developed because it's a safe threshold. If you have a 15% drop, then that's usually significant. Certainly, if it's over the last couple of years. If you have a more than 15% drop from, say, 20 years ago, it may not be so important, but you can actually plot out the serial decline using a computerized algorithm, and that will give you the predicted decline for FEV1. But there are problems with it either way. The best thing to do if you have a change in spirometry, which is quite big, is to repeat the spirometry and make sure they haven't had a chest infection in the last few weeks, or that they don't have asthma. Because if you've got asthma, you should be doing a post bronchodilator reading, because it definitely increases the variability. And asthma is the commonest, that and infections are the commonest reasons for it.
Okay. David, I know that you touched on this in your presentation. I'll just read out the question in case you did want to make any further comments. How do you manage the range of non-disease related abnormal spirometries?
Yes, it's well, as Professor Yates said, the most common things we're seeing are asthma and COPD. And the COPD is a mixture of three-quarters of them are smokers, and so it's often a mixture of probably smoke and some degree of mine dust exposure that's often hard to be sure of. But we always identify maybe 3 or 4 cases of sarcoidosis during the year. We normally flag 1 or 2 cases of hypersensitivity pneumonitis, and then we get all sorts of other unusual lung conditions. And once again, if we can identify a disease process, then from our point of view, our management is looking at what degree of impairment do they have and matching that to a recommended dust limit. So when we talk about dust restrictions, there's a statutory limit that applies to every coal worker. And then what we do is say these workers should be working in areas where the average exposure they get is a fraction of that occupational limit. So as their disease gets worse, the average exposure that we allow them to be exposed to gets lower and lower.
Okay, well, that's all the questions. So thank you so much. I would just really like to thank all of our presenters. It's been a pleasure, really informative and really useful. So thank you so much for taking the time. To everyone who's joined us online, we appreciate that it's, dinner times, down times, spend time with your family time on really bad days, cram extra work time. So we do appreciate you taking the time and spending your evening with us. Please take care of yourselves. Thank you so much, everyone.
Thank you.
Thank you.
Thank you.